Welcome to the Depth Dive. Today we're really digging into gastroenterology and hepatology. If you're looking for a way to quickly grasp those classic patient presentations in GI and liver disease, well, you're definitely in the right place. We've lined up 10 detailed clinical cases, patient histories, symptoms, lab results, and our mission today is pretty straightforward. Find those really specific, sometimes missed clues, those concordance hints to help diagnose and manage some tricky conditions.
Exactly. You can think of this deep dive as really an exercise in pattern recognition. In clinical practice, knowing precisely how someone presents, maybe it's a specific nutrient deficiency, or that unusual mix of lung and liver issues, or even just when their pain hits relative to meals that can let you cut through the noise. You know, bypass tons of possibilities and get right to the likely diagnosis. We're here to decode those flags.
Sounds like a valuable shortcut. Okay, let's jump into section one. We're talking about the diagnostic power of deficiencies and genetic markers. First up, case one, coeliac disease and malabsorption. So we have an adult, chronic diarrhea, bloating, and specifically iron and folate deficiencies. What's the immediate thought there?
Well, the chronic diarrhea and the bloating, that screams malabsorption right away. But what makes this classic for celiac disease, like you said, is the pattern of deficiencies, iron and folate.
Okay, let's unpack that a bit. Why is that specific combination, iron and folate, so significant?
It's all about geography, really. Where are they absorbed? Iron and folate uptake happens mostly way up high in the small intestine, the duodenum, and the proximal jejunum. And in celiac disease, that's exactly where the gluten-triggered inflammation and damage, the neuropathy, hits hardest. So finding those particular deficiencies is like a signpost. It points directly to a problem with absorption right there in the upper small bowel, likely from that gluten damage.
Ah, okay. So the symptoms and the labs are literally mapping out where the disease is physically located. Makes sense. How do we, confirm it?
First stop is usually serology. The go-to test is the serum IgA anti-tissue transglutaminase antibody, the TTG-IgA. But, and this is crucial, you also need to check the patient's total IgA level at the same time.
Right. Why the total IgA check?
Because some people, it's actually not that uncommon, have selective IgA deficiency. They just don't make IgA antibodies properly. So if you only run the TTG-IgA test, you could get a false negative, even if they definitely have celiac disease. Checking the total IgA level, make sure the TTG test is even interpretable before you proceed to the gold standard, which is the duodenal biopsy, to see the damage.
Oh, okay. That connection between gut damage and specific deficiencies is a great starting point. Let's switch gears completely now. How about a single genetic issue causing trouble in two very different systems? Case 3, alpha-1 antitrypsin deficiency, the liver-lung paradox. We've got a young non-smoker, but they have severe chronic lung disease, maybe emphysema, and signs of liver trouble like jaundice.
Yeah, this is a really, really important one, a major red flag combination. You absolutely have to suspect alpha-1 antitrypsin deficiency, or AATD, in this scenario, especially a young non-smoker who develops emphysema that predominantly affects the lower parts of the lungs, what we call lower zone predominant panacenar emphysema.
Wow. So young person, bad lungs, never smoked, and liver issues. That just sounds contradictory. How does one genetic defect manage to damage both organs?
Think of it like this. The AK protein is made in the liver. The mutation causes two main problems, kind of a double whammy. First, there's a toxic gain of function in the liver. The mutated protein gets made incorrectly, it misfolds, and then it gets stuck inside the liver cells, the hepatocytes. It gums up the works, basically. This buildup causes inflammation, potentially leading to cholestasis or even cirrhosis over time. Then there's the loss of function effect, mainly in the lungs. Because the faulty protein is trapped in the liver, not enough normal AAT gets out into the bloodstream to do its job. And its main job is protecting the lungs from an enzyme called neutrophil elastase. Without enough AAT, this enzyme runs wild and chews up lung tissue, causing emphysema.
So it causes damage by building up where it shouldn't, in the liver,
Yeah.
and also by not being where it should be in the lungs. That's a really clear way to put it.
Exactly. So to confirm, the best next step is simple. Measure the serum level of alpha-1 antitrypsin. If it's low, then you move on to phenotype or genotype testing to pinpoint this specific mutation, usually looking for that severe ZZ variant.
Okay, let's transition now into section 2, focusing on acute crises. We're moving from those subtle chronic clues to real emergencies. Case 2, acute pancreatitis. Classic story. Sudden, awful pain in the upper abdomen, boring straight through to the back. Maybe they have a history of gallstones, maybe heavy alcohol use. When you see that patient, what's the single best initial diagnostic test?
Serum lipase. Amylase often gets mentioned, but lipase is generally better. It's more sensitive and crucially, much more specific to the pancreas. Amylase can go up for other reasons, like salivary gland problems, mumps, things like that. Lipase is more reliable for pancreatitis.
That's a key distinction. What about imaging then? Do we immediately send them for a CT scan?
Not necessarily right away just to diagnose it if the clinical picture and lipase are clear. The first imaging step is usually an ultrasound. You want to look for gallstones because they're such a common cause. A CT scan, especially with contrast, comes in later, offered to assess for complications like pancreatic necrosis or fluid collections, or if the diagnosis just isn't clear-cut.
In talking about complications, there's an interesting follow-up scenario. Say that same patient gets better, goes home, but comes back later with a swollen belly and pneumocytes, fluid in the abdomen. What should that make us think?
That specific sequence, pancreatitis followed by pneumocytes, should immediately raise suspicion for a ruptured pancreatic pseudocyst. Basically, the pancreas leaking fluid, and you can confirm that suspicion pretty easily. If you sample that acidic fluid and find a really high amylase level in the fluid itself, that links the previous pancreatitis directly to the new fluid buildup.
Okay, shifting to another emergency, case 4. Perforated peptic ulcer. This sounds terrifying. Sudden, severe epigastric pain. Their abdomen is rigid like a board. Maybe they're tachycardic, hypotensive. And the x-ray shows free air under the diaphragm. What's the immediate plan?
Yeah, this is a surgical catastrophe unfolding. It means peritonitis, possibly leading to shock. So management has to be immediate and aggressive. First, resuscitation IV lines, lots of fluids, oxygen. Then broad-spectrum IV antibiotics immediately because gut contents are leaking into the abdomen. Keep the patient NPO, nil by mouth. And crucially, get an urgent surgical consult. They need operative repair. The typical fix is an omental patch repair where they use a bit of fatty tissue called the omentum to plug the hole in the stomach or duodenum, often done laparoscopically these days, but the key is speed. You're racing against sepsis.
And our last acute crisis for this section, case 5, variceal hemorrhage. Patient comes in with melena, those black, tarry stools, a sign of a major upper GI bleed. What are the external clues, the things you see on the patient that immediately scream, this is likely a life-threatening variceal bleed from liver disease?
Right? You need to connect the bleeding to the underlying cause. You look for the classic stigmata of chronic liver disease, specifically cirrhosis, things like spider naive, those little red vascular spots on the skin, especially the upper body, and maybe gynecomastia, which is breast tissue enlargement in men. Seeing those signs strongly points towards cirrhosis causing portal hypertension.
That clinical link is so important. You see the skin signs of cirrhosis, you see the bleeding. You immediately think the esophagus could be the source?
That's precisely. The cirrhosis blocks blood flow through the liver, backing pressure up into the portal vein that's portal hypertension. This forces blood into alternative, weaker veins, particularly in the esophagus and stomach, forming varices. These can rupture and cause massive bleeding. So immediate steps are resuscitate, start vasoactive drugs like terlipressin or octreotide to lower portal pressure, give IV antibiotics because infection risk is high, and arrange an urgent endoscopy to ban the bleeding varices.
Let's move into section 3 now, focusing on decoding autoimmune liver disease. Case 6 presents autoimmune hepatitis, or AIH. We're looking at a young woman. Her liver enzymes, AST and ALT, are really high, and notably, she's already being treated for hypothyroidism.
Yes, and that history of hypothyroidism is a really important clue. Why? Because AIH typically affects younger or middle-aged women, and it very often travels with other autoimmune conditions. Hashimoto's thyroiditis, which causes most hypothyroidism, is found in something like 10 to 23% of AIH patients. So that existing diagnosis significantly raises the suspicion for AIH.
So the coexisting autoimmune issue is that concordance piece we're looking for. What's the next diagnostic step when you suspect AIH?
Well, after making sure it's not viral hepatitis, you need to check serum IgG levels that are often very high in AIH and order specific autoimmune markers. That includes ANA, anti-nuclear antibody, SMA, smooth muscle antibody, and sometimes anti-LKM, anti-liver kidney microsomal antibody. Ultimately, a liver biopsy is usually needed for confirmation, and the treatment involves starting immunosuppressants pretty early on.
Okay, now let's contrast that with case 7, primary biliary cholangitis, or PBC, a different beast altogether in autoimmune liver disease, right?
Completely different, yes. PBC primarily targets the small bile ducts within the liver. This leads to cholestasis, impaired bile flow. So the typical patient, often a middle-aged woman again, presents differently. Symptoms are often debilitating itching or pruritus and profound fatigue. And the key lab abnormality isn't the asphalt, but rather a markedly elevated alkaline phosphatase, or ALP. And the serological marker is also totally distinct. For PBC, the hallmark is a positive anti-mitochondrial antibody, or AMA. This antibody is incredibly specific for PBC.
I've heard the AMA, especially the M2 subtype, is almost diagnostic on its own.
It's highly, highly specific, yes. Generally, the diagnosis requires meeting 2 out of 3 criteria. That cholestatic pattern of liver tests, high ALP, a positive AMA, or liver biopsy findings consistent with PBC. And importantly, the treatment isn't immunosuppression like AIH. For PBC, the standard of care is starting ursodeoxycholic acid, or UDCA. It's a bile acid that helps improve bile flow and can slow disease progression.
All right, let's wrap up with section 4, chronic GI and metabolic conditions. Starting with case 8, GERD and chronic cough. This is such a common problem in clinics. An obese patient, chronic dry cough, maybe worse at night, some halitosis, heartburn. But crucially, their pulmonary function tests, their PFTs, are totally normal.
Those normal PFTs are the absolute key here. They essentially rule out common lung diseases like asthma or COPD as the primary cause of the cough. So you have to think outside the lungs. And given the heartburn, the nocturnal symptoms, the obesity, reflux-related chronic cough driven by GERD becomes extremely likely. The reflux can trigger coughing in a couple of ways, either tiny amounts of stomach acid getting aspirated into the airways, or sometimes just via a nerve reflex linking the esophagus and the airways.
So the answer isn't necessarily an inhaler.
Exactly. Management starts with lifestyle changes. Weight loss is huge, maybe elevating the head of the bed. Then you do a therapeutic trial of a proton pump inhibitor, a PPI, usually for a good 8 to 12 weeks, to see if suppressing the acid stops the cough. Oh, and one important point, given the obesity and night symptoms, you should also strongly consider screening for obstructive sleep apnea, OSA. GERD and OSA often go hand in hand and can make each other worse.
Okay, case 9 gives us a really neat diagnostic clue telling gastric and duodenal ulcers apart just based on timing with meals. We have a patient epigastric pain, but also diarrhea, and the pain gets better when they eat.
Pain relief with eating is the absolute classic sign of a duodenal ulcer. Think about it. When food enters the stomach and duodenum, it temporarily buffers the stomach acid and can stimulate bicarbonate release, giving relief. If the pain consistently got worse right after eating, that would point more towards a gastric ulcer because eating stimulates more acid production right away.
Interesting. But what about the diarrhea mentioned in this case? That doesn't sound like a typical ulcer symptom.
No, it's not typical, and it's a definite red flag. Significant watery diarrhea, especially if the ulcers are multiple, unusually located, or hard to heal, should make you consider an acid hypersecretory state. The main one to think about is Ollinger-Ellison syndrome, caused by a gastrin-producing tumor, a gastrinoma. The massive amount of acid overwhelms the small intestine's buffering capacity and can interfere with enzyme function, causing diarrhea. But standard initial steps are still usually starting a PPI and testing for H. pylori infection.
Right. And finally, let's wrap up with case 10, managing NASH-H and NEFLD, non-alcoholic steatohepatitis in someone with obesity and type 2 diabetes. This is incredibly common now. What's the single most important first step in management?
You have to remember what drives NASH. It's essentially the liver's manifestation of metabolic syndrome and insulin resistance. So, without a doubt, the single best, most crucial initial step is addressing the underlying metabolic issues. That means comprehensive lifestyle modification focused on weight loss and better metabolic control, particularly glucose control. Now, while lifestyle is number one, medications can help, especially in patients who also have diabetes. Metformin is often considered first line for diabetics with NAFLD. Pioglitazone is another option that's actually shown some benefit in improving liver histology in NASH, although you have to consider its side effects. But lifestyle remains the foundation.
So looking back across all 10 of these scenarios, it's really striking. There's a common thread, isn't there? How these specific clusters of findings like iron and folate pointing to the duodenum, or spider-nevi signaling varices, or that AMA antibody nailing down PBC, how they act as these really powerful diagnostic shortcuts.
That's absolutely the key takeaway. Knowledge is one thing, but applying it effectively is another. We've seen again and again today how good internal medicine often involves linking these seemingly unrelated clues, maybe something you see on the skin, or a specific pattern in the blood test directly back to what's happening with an internal organ. The body leaves clues, you just need to know how to read them.
And maybe here's a final thought for you, the listener, to consider. Just how deeply interconnected is the gut with everything else? We talked about how something as common as a chronic cough, which seems like a lung issue, might actually find its solution with a gastroenterologist treating acid reflux. It really makes you think about the profound systemic connections we've touched on today and why looking at the whole patient picture is so vital. That concludes this deep dive. We hope we've given you some useful shortcuts and insights into the guts of the matter in GI and hepatology.